Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care and healthcare in general. Here's your host, Dr. Hassaballa.
Hello, everybody. Happy to have you with me. All right, so this is the latest episode of Journal Club, where we discuss pertinent articles that have been recently published in the critical care literature. And so the time of intubation, when you have to intubate somebody, meaning putting an endotracheal tube, a tube in the throat to connect a patient to an invasive mechanical ventilator, can be fraught with danger. We place people on mechanical ventilation because they can't oxygenate, or they can't ventilate, meaning oxygenate. They cannot maintain an oxygen saturation of, between anything greater than 88 or 90%, depending on the patient. Or they can't ventilate, meaning their carbon dioxide levels keep rising. Or they're not awake enough to maintain a patent airway. Those are the three main indications for endotracheal intubation. It's a time that can be fraught with danger because sometimes patients are placed on mechanical ventilation while they're awake because they have very dangerous, very difficult airways. Most of the time, however, patients are sedated deeply and paralyzed a lot of the time, meaning their muscles are completely paralyzed, and to facilitate placement of the endotracheal tube into the airway. Now that period is dangerous. If you have somebody with severe pneumonia and their oxygenation is compromised from the very beginning, even before, once you sedate them and you paralyze them, there is danger that the oxygen level is going to go down, that they're going to become hypoxic. And when you become hypoxic, other than COVID, during COVID, people became severely hypoxic and nothing happened. Absent COVID, that time is very dangerous. You could suffer cardiac arrest. The body just cannot tolerate severe levels of severely low oxygen levels for very long, and there's definitely a risk, or a risk of anoxic brain injury, meaning lack of injury to the brain because of lack of oxygen. So intubation it can be potentially very dangerous for the patient. And so there are various ways to pre-oxygenate, meaning give the patient enough oxygen before the procedure of intubation, so to protect against that period of low oxygen after intubation. And so there's, typically you can do it either by a mask, just a mask over the nose and mouth that provides oxygen as high as 100%. Or the other way is to put someone on noninvasive mechanical ventilation, meaning a tight-fitting mask over the nose and mouth with a machine pushing air into the lungs. The simple mask is easy to do. You can just put the mask on the nose and mouth. But if you're breathing fast, you can pull in a lot of room air, and then you reduce the practical oxygen that's going into the lungs. And according to this article that we're discussing, it says that the actual fraction of oxygen may be as low as 50% when you breathe room air around the mask. The non-invasive ventilator, meaning the tight-fitting mask, is an alternative, but not a lot of people, it's not always available, and theoretically there is a risk for aspiration, meaning because all that air, it goes through the path of least resistance, and it a lot of times goes into the stomach and makes the stomach big, and then that puts you at risk for vomiting and then aspiration, inhaling of gastric contents into the lung. And so those are the risks of each type of method of pre-oxygenation. And so the question is one better than the other, right? And so enter this study that was published in the New England Journal of Medicine in June of this year. It was actually published on June 13th. It's called the Preoxy trial, right? And so what they did was, this is a multi-center randomized trial conducted at 24 emergency departments and intensive care units in the United States. And what they did is they randomly assigned critically ill adults, meaning people over the age of 18, who are going to undergo tracheal intubation to receive pre-oxygenation with either non-invasive ventilation or an oxygen mask. Okay? And the primary outcome was hypoxia hypoxemia during intubation, which they defined as an oxygen saturation of less than 85% during the interval between induction of anesthesia and 2 minutes after tracheal intubation. Less than 85% is pretty low, right? So that's the target. It's not 90%. It's less than 85%. They left it up to the investigators to determine what kind of mask and how much oxygen and what kind of non-invasive ventilation that they give. So it was kind of a pragmatic, what they call a pragmatic trial. Okay, and it's so, but they said you have to give they offered best practices, right, for each way. And so for non-invasive ventilation, they said that the FiO2 should be 100% with an expiratory pressure of at least 5 centimeters of water and an inspiratory pressure of at least 10. Okay, so at the very minimum, you have a BiPAP of 10 over 5 with an FiO2 of 100%, or an oxygen mask which at greater than or equal to 15 liters per minute of oxygen to be given for at least 3 minutes before the induction of anesthesia, if feasible. Okay, so that's how they did it. Then they left it up to the investigators. So they ended up randomizing 1,301 patients to each, and then there were 645 in the non-invasive ventilation group that were included in the intention to treat analysis, and there were 656 patients who were included in the oxygen mask group in the intention to treat analysis. Okay. They screened over 4,500 patients, and then there were a lot of patients who were excluded. The study was conducted between March 10th, 2022, and October 14th, 2023. And so what they found was that the group who had the non-invasive, mechanical ventilation had less hypoxia during intubation. It was 9.1% in the non-invasive ventilation group versus 18.5% in the oxygen mask group. Okay. Now, as far as outcomes, there were more days of ventilator-free days in the non-invasive group, 21 versus 17. There were more ICU-free days, 16 versus 14. And in-hospital death was slightly decreased, 32.4% versus 33.1%. But I don't think they were studying this. They just talked about the outcomes. And operator reported aspiration was 0.9% in the non-invasive group versus 1.4% in the oxygen mask group. So now at 24 hours, both groups had the same FiO2 of 40%, and the median oxygen saturation of both groups at 24 hours was the same at 97%. Both groups had an equal amount of pneumothorax, 7 in each group. Interestingly, there was 1 cardiac arrest in the non-invasive ventilation group versus 7 cardiac arrests in the oxygen mask group. And so what they're saying is, what they said was, not in this trial, adults who underwent non-invasive mechanical ventilation to pre-oxygenate had less hypoxemia during intubation than oxygen mask group. And they did not have more aspiration, because that's the fear of placing people on non-invasive mechanical ventilation. And so, for me as a practicing intensivist, I think I find this study very interesting, and I think probably practice changing. I have had people on non-invasive who are already on non-invasive mechanical ventilation. We turn the FiO2 up to 100% and then use that as a pre-oxygenation. And now I feel a lot better to know that there's actually evidence behind this. And in fact, I do plan on changing my practice, that if I can, if feasible, I am going to place people on non-invasive mechanical ventilation prior to intubation and use that as a method of pre-oxygenation. Usually the respiratory therapists bring the ventilator into the room anyway, so I'm just going to connect them to the ventilator using non-invasive mode, at least 10/5 with 100% FiO2. And if they're already on non-invasive, turn the FiO2 up to 100% and pre-oxygenate them for 3 minutes while I get set up, while I get everything ready. And this study suggests that they should have less of a chance of getting hypoxia during intubation. So I think this was a really good trial. Now, They did mention the strengths of the trial, and I'll go over. I'll repeat them here. They enrolled a large sample of patients, which provided sufficient statistical power to detect clinically meaningful differences. They conducted the trial in EDs and ICUs at multiple sites, and they enrolled critically ill adults with a broad range of conditions, which increases the generalizability of the findings. Which is, so it's not just a very narrow patient population that was studied that limits the ability to generalize to the general critically ill population, right? And now they also mentioned limitations because they excluded people who were already receiving positive pressure ventilations, right? So somebody who was already on BiPAP or CPAP, and then you end up intubating them, they excluded them from the trial, right? And then they also excluded 8.5% because they had vomiting, hematemesis, throwing up blood, hemoptysis, or epistaxis, and another 0.8%, 38 patients were excluded because clinicians otherwise perceived them to be at very high risk for aspiration. So again, that if people were already vomiting, they didn't include them in the trial because that might confound the results. All right, and I guess that makes sense, but that is a limitation of the trial. And they also didn't use high flow nasal cannula, and because that's another way to give oxygen is high flow nasal cannula. They did not include them, and this really couldn't be blinded, right? Patients, clinicians, and trial personnel were aware of the trial group assignments, right? Because this really can't be a blinded study because you're seeing right then and there that they're either on an oxygen mask or they're on a non-invasive ventilation. Still, those strengths, those limitations notwithstanding, I think for me this is practice changing, and I will do the best I can, if feasible, to pre-oxygenate patients that I am planning to intubate with non-invasive mechanical ventilation as much as possible. And this study shows that there is good evidence that it does protect patients from becoming hypoxic in the interval before, after induction of anesthesia and 2 minutes after intubation. So really good study, and for me, it'll be practice changing. Thank you so much for your time and attention. And until next time, this is Dr. Hassaballa signing off on the Healthcare Musings podcast. Thank you for listening. To get every episode delivered directly to your inbox, please subscribe at healthcaremusings.com.